Okay, so we're going to get started with Perfusion 1. Now, my slides that have the learning objectives on them, the goal of these is so that at the end of the lesson, you're able to go back to these learning objectives and have met each one. So for example, our first one, prioritize appropriate nursing interventions to manage common problems and needs of critically ill patients. This would be you determining, okay, so what nursing interventions am I going to do for this type of equipment? What is it going to prevent? How is this going to ensure that the patient meets their optimal outcome? So really pay attention to these learning objectives that I have on each of our presentations. Okay, so for our nursing assessment, when we're looking at the patient, we want to note their general appearance. Are they pale? Do they appear weak or tired, exhausted? This could indicate that they have decreased blood pressure, decreased cardiac output. Same thing goes for level of consciousness. We want to know, are they alert? Are they lethargic? Are they in a stupor? Are they in a coma perhaps? Those types of things. Skin color and temperature, so cool, pale, potentially some diminished peripheral pulses. Definitely want to look at their vital signs, and then urine output. Urine output is very important because anytime there is decreased perfusion, the body will actually sacrifice the kidneys first. So a decreased of urine output, so anything less than 30 mLs per hour, we would deem that oliguric, and that patient potentially has some issue with their circulation. Okay, so for hemodynamic monitoring, so this is the measurement of pressure, flow, and oxygenation within the cardiovascular system. It can assess the heart function, fluid balance, and then also the effects of any drugs that we're giving on cardiac output. Okay, so this is going to be one of your assignments. You have a matching activity for some terms for hemodynamic monitoring. Okay, so some things that we get with invasive and non-invasive measurements. So anything invasive, think that this is an equipment that's put inside the body, and then non-invasive is usually something that measures outside of the body. So we can get our central venous pressure, pulmonary artery wedge pressure, and then cardiac output or cardiac index, which is your cardiac output adjusted for your BMI. So just to refresh on that word matching activity, so we've got cardiac output, which is going to be your amount of blood that's pumped by the heart in 1 minute. Okay, and how we get that is, you probably remember from second semester, cardiac output is your stroke volume times your heart rate. And it should be, according to your book, around 4 to 8 liters per minute. What I see in the hospital setting is they like it a little bit more than that, but going by your book, 48 liters per minute for your cardiac output. And then you have your cardiac index, so adjusted for your BSA, and then your stroke volume. So this is volume injected with each heartbeat, and then your stroke volume index, so it's adjusted for body size as well. And your stroke volume, how you would get this would be your cardiac output divided by your heart rate. And this should be about 60 to 150 mLs per heartbeat. Okay, so for vascular resistance, so systemic vascular resistance, so it's the resistance of the systemic vascular bed, so everything that's kind of pushing against the heart beating, if that makes sense. Pulmonary vascular resistance is resistance of the pulmonary vascular bed. So you know that when the heart beats, it goes to the lungs first, gets oxygenated, goes back into the heart, and then it's pumped to the rest of the body. So as the heart tries to push blood into the lungs, that resistance that the lungs is giving it through those vessels, that's going to be your pulmonary vascular resistance. When that left ventricle goes to pump the blood to the rest of the body, that's going to be your systemic vascular resistance. Contractility, there's no real way to measure the contractility of the heart. So it's reduced, trying to explain this well. So it's reduced like in a failing heart, or if a heart is beating really fast. So the heart's a muscle like anything else. So if you have any like cardiomyopathies, or if the heart's beating fast for a long period of time, some of that tissue becomes fibrotic, and then your heart isn't able to pump as effectively. It's kind of a similar premise to why an athlete has a very low heart rate, because they have such good contractility that they're in such good shape that their heart is able to maybe beat only 50 times per minute, but it's still able to meet the body's needs with each pump because of their increased contractility. So with preload, the volume of blood within the ventricle at the end of diastole, what you need to remember about this, so for diuresis and vasodilation, these decrease preload. So they decrease that pressure, that volume of blood that's within that ventricle at the end of diastole. If you give fluid administration, that's going to increase your preload. Okay, so for afterload, so increased afterload, this often results in decreased cardiac output and increased oxygen demand. So ways that we can decrease afterload, so we can give vasodilators. So vasodilators, what they're going to do is they're going to decrease that systemic vascular resistance because they're going to dilate those blood vessels. So that decreases the amount of pressure that the heart has to pump against, therefore decreasing the afterload. So these are the components of a pressure monitoring system. And for those of you that are in the ICU for your clinical, there's a high probability that you're going to be able to see this in person. I highly recommend that you kind of talk with your precepting nurse, or your clinical instructor to kind of show you this in person. It is helpful. But here, just kind of looking at it, so we've got a pressure bag up at the top, and basically this pressure bag, we used to use heparinized saline because the thought was that if we had saline with some heparin in it, it would keep the line more patent, I should say. But then they found that patients were developing HIT and a sensitivity to heparin because of it. So now what we use is only normal saline. So depending on the pressure bag, this one here looks like it's a liter. So we can use a liter of normal saline, or some pressure bags are intended to use a 500 ml bag of normal saline. And basically what this does, so there's a little, you can see like the little white adapter at the end of the bag right next to where the saline, where you would spike your saline. So this has a pump on it, and what we would do is we would pump this up to 300 millimeters of mercury, and what it does is it's basically just squeezing that bag, okay? Of course, this is after you prime the line with the saline, and it's really important at this point that we do not get any air bubbles in the line. So pump that up to 300 millimeters of mercury, and then the tube actually stays clamped, but at that high pressure, it's still delivering a little bit of fluid, even though the line is clamped, because it's such high pressure squeezing that bag. So what it's delivering is at about 3 mLs per hour, and basically this is just to ensure that that line stays patent. So moving down the line, you see that there's a 3-way stopcock. So this is good if you're using the device and for flushing. So what we perform, like a fast flush, is when we would actually, there's a little tab that you would pull that would open up the you can see a little lower than that, the fast flush device. It's basically a little rubber tab that you pull that like opens up the bag, and it flushes it at 300 millimeters of mercury. So it flushes it at a high pressure into the patient's arm. Again, to just if we want to reestablish our pressures, this is a good way to do it. Go ahead and do a fast flush. So our transducer cable, so that hooks up to the monitor. You can see where that goes up to the monitor. And then towards the end, you have another 3-way stopcock, and this is good for connection for specimen collection. So you would turn the stopcock off to the bag, and then you would go ahead and flush the line, and then you can pull back and get some blood for some sampling. So this would be your pressure monitoring system that you'll see. Okay, so this graph is showing you a arterial line. So to get an arterial blood pressure, this is the most accurate form of blood pressure, better than getting a manual or an automatic machine blood pressure. So with this, you can see the dichrotic notch is lost. So if you look at that first kind of shadow of a tracing, about halfway down, you see that there's a little notch, right? But then as you start to see the waveform, it's getting kind of lazy, right? So you have your systolic, your mean arterial, and your diastolic pressure. And when it has that dicrotic notch, that waveform is reliable for what the patient's blood pressure is. But you can see when you lose that, it's going to be lower than what it actually is. So if you look at the top where we're going to do that fast flush that I talked about on the previous slide, that is basically flushing the line at 300 millimeters of mercury of pressure. So imagine if your systolic was 300, that would be really, really high. So you can tell that when you open up, when you pull that little tab, it's flushing it in at a high, high pressure to just kind of reset the system. And then once you do that fast flush of just the normal saline, then the pressure will hopefully come back and pick up, and you'll have that dicrotic notch back. So where we want to place that transducer, and oftentimes that transducer on the pressure monitoring system, oftentimes you'll see it like taped on the side rail. This is only helpful, initially, but, as we're boosting and moving patients around, sometimes that does have to be repositioned. So we look for the phlebostatic axis, the fourth intercostal space, mid-chest. So the phlebostatic axis is the name of the point that we're actually looking for. So we want to get the transducer as close to that point as possible. So, and then we're going to do something called zeroing, and it kind of goes back to where I was talking about that initial three-way stopcock. If we turn it off to the patient, because we don't want blood to come back up through the tube, so we're going to turn it off to the patient, and then we're going to open it towards the environment. And what that does is it's the environment, the atmospheric pressure is 0. So we're zeroing it by opening up to the environment, and just to kind of, and then your pressure, just like how it was on that last slide, your pressure should drop down to 0 on the monitor because it's getting the level of the atmospheric pressure. And then after we do that, we're going to close it off, and then we're going to open it back up from the patient, and then that's zeroing your equipment. So you want to do that initially with the setup. You want to zero it to the environment, and then periodically afterwards. Okay, so going back to arterial blood pressure, so this would be your art line. So this is inserted by a physician. It's a sterile procedure. So it's inserted into the peripheral artery, it's sutured in place, and then that arm is immobilized while the patient has it in. If this catheter should come out, there is a potential to bleed out from it because it is in an artery. So we have to be really careful to make sure that it's immobilized well, and that, with our patient education as well. So going back to another tracing of our arterial pressure, so we have our dicrotic notch, so we get our systolic and our diastolic, and again, this is the most accurate, and it should correlate with the patient's EKG as well. So when you're looking at the QRS, that very last point of the S should match up with that dicrotic notch. So our complications with having an art line. So as I mentioned before, hemorrhage, because it isn't an artery, infection as well. Any invasive device is a risk for infection. Any foreign object inserted into the body, it's going to pose a risk for infection, especially the longer that it's left in, because bacteria like to congregate on that. Thrombus formation is going to be another risk. Neurovascular impairment, there's a lot of nerves in the wrist where it's inserted, so they could potentially have some neurovascular impairment. And then rarely, however, it is still potential complication is loss of the limb. If, they do sustain an infection, something along those lines, maybe they have some comorbidities, diabetes, poor wound healing could result in loss of limb. So we have our case study patient here. So AJ is admitted to the ICU with decompensated heart failure. When planning care for AJ, what nursing interventions will you perform to prevent complications related to his arterial line? So I want you to take a moment and, pause this presentation and just write down, knowing what complications could occur, what are you going to do as a nurse to prevent these from occurring? So our continuous flush irrigation system, so we have that setup that's delivering those 3 mLs of saline per hour, keeping the line patent, limiting thrombus formation as well. Okay, so what we should be assessing as the nurses is we want to make sure that the flush bag, that it contains whatever amount of saline it's prescribed for. So if it required a 500 ml bag or a liter bag. And we also want to make sure that that pressure bag is always inflated to 300 millimeters of mercury. Anything less than that, they're not going to be getting the full 3 mLs per hour. Okay, so moving on to our pulmonary artery catheter. So you're gonna see this as PA catheter. You might see it as POP. You might see it as Swan-Ganz. All these terms are kind of used interchangeably, but what it is, it's a pulmonary artery catheter inserted into the heart. So this is the most invasive device. A lot more complications related to this. So we have to look at it as how important is it for the patient. We have to look at the risks versus benefits of them having this equipment. So with our pulmonary artery catheter, our pulmonary artery pressure or our pulmonary artery wedge pressure, this is going to increase in heart failure or any types of situations where there's fluid volume overload, and then it's going to decrease with volume depletion. The good thing about having the PA catheter inserted is that, even though there are a lot of complications, it does allow for precise manipulation of the preload, meaning that the drugs that we're giving or fluid therapy, we can restore fluid balance, restore fluid balance while limiting overcorrection or undercorrection of the problem. So, when patients are giving fluid, it's kind of, we look at the urine output, we look at the blood pressure to kind of guide, how much fluid they're going to be getting. We look at the electrolytes, but this allows, for us to give the, almost the exact amount of fluid that they need without giving too much or too little. Okay, so our PA catheter, Swan-Ganz. So this is kind of tricky to talk about. We're going to walk through it, and then I do have a nice picture of it that we can, so I'm actually just going to skip this slide. Okay, so here's the picture. So your PA catheter, I typically see this inserted through the jugular, and it's connected to the right side of the heart. And then ultimately it's threaded through the heart, and that distal lumen port is going to be sitting in that pulmonary artery, and this is where we're able to obtain our pulmonary artery wedge pressure. So there's going to be 2 proximal lumens you can see on here where the exit ports, in the right atrium and right ventricle, if there's 2, which we have 2 here. So the right atrium port is used for measurement of your central venous pressure, which we will talk about. We can also use that for injection of fluid for cardiac output determination, and we can also use that just to take blood specimens. Second proximal port, that's used for infusion of fluids and drugs, or blood sampling. Thermistor, so you see that thermistor connector that's connected to that cardiac output computer. So this is wired to measure the core temperature of the patient. Okay, so this picture very clearly kind of outlines how it's threaded through the heart. So that balloon is going to be inflated because initially when they're putting this through the heart, they want the blood flow to kind of pull that balloon through. And you can see on there, depending on where that balloon is at, this is connected to the monitor, you can see what the pressure reading is. Once it gets to that pulmonary artery at that very last picture, you can see that should be the rhythm that you should see for that pulmonary artery wedge pressure. So with our pulmonary artery wedge pressure, it used to be where they would want to show other nurses. I know when I was a new graduate, they'd be like, come look, I'm going to do, the wedge pressure. But they found that inflating the balloon too much, can actually lead to damage in the heart. So it's usually an ordered measurement. So potentially going in every 4 hours to obtain the pop or, whatever, is ordered by the physician. So how we're going to do this is we're going to slowly inflate the balloon with maximum of 1.5 mLs of air until we see that tracing that we saw on the previous slide that shows the pop waveform. And this will give you that, that wedge pressure. However, we don't want to inflate it for too long, again, because it's blocking circulation when we inflate that balloon. So no longer than 8 to 15 seconds to obtain that pressure. Okay, so this is the effects of an overinflated balloon. So this is called over-wedging. If the balloon is over-wedged, you see that line change. It can actually rupture the pulmonary artery from the pressure of the balloon. So this is suspected when that waveform looks wedged spontaneously, or when less than 1 ml is needed to wedge the tracing. That means that there's still some air left in that balloon, meaning that you're putting additional air in there, over wedging that balloon. Okay, so moving on to a CVP. So this is, along with the art line, is pretty common, to see patients in the ICU that have a CVP inserted. So this can be obtained from the PA catheter, as I mentioned, but oftentimes we'll just have a central line in. And what you're going to see most is a triple lumen central line. So with your CVP, so it's a measurement, as we talked about before, of that right ventricular preload and reflex fluid volume status. So an elevated CVP, this would indicate fluid volume overload. A low CVP, or in heart failure, a low CVP indicates hypovolemia or fluid volume deficit. So similar to your POP as well. Okay, so moving on to systemic vascular resistance. So an increased SVR, so this indicates vasoconstriction. So you can imagine if you have a straw clamped and you're attempting to blow air into it, it's going to be very difficult, if not impossible, to get any air through. It's similar with your heart trying to pump against an increased SVR. With a decreased SVR, so this indicates vasodilation. This is actually a more ominous sign. This happens kind of almost when the body is has given up, or for overuse of vasodilators or something along those lines. But a decreased SVR typically happens with shock states where you have that massive vasodilation, and then the heart's trying to pump against, and there's too little resistance for it to pump against, which means there's going to be a significant drop in blood pressure. So complications with PA catheters, so infection and sepsis. So as I mentioned before, that any invasive line is considered a risk for infection. So very careful sterile technique for insertion, and then making sure that we maintain the catheter using asepsis is required to prevent infection. So the skin is usually cleaned with the chlorhexidine preparation, sterile occlusive dressing, a large tegaderm. And then we're going to keep monitoring that site for local and systemic signs of infection. So local would be like your redness, swelling, pain, exudate, looking for any type of abnormal drainage or crusting. And then for systemic, we would be checking the white blood cell count, and also checking for fever as well. Also to prevent infection, the flush bag, the pressure tubing, and the transducer and stopcock are changed every 96 hours. Reason being, again, tubing that's left sitting can be environment for bacteria to grow. So another risk is air embolus. So if for some reason there is a disconnection at the site, we're putting and air gets into the line, that can cause an air embolus. Or if the balloon itself ruptures and we inject air into it, we can be giving a patient an air embolus right into their heart. So we want to make sure that our, all of the Luer lock connections are tight, that three-way stopcock is set appropriately, and that all of the alarms are on as well. So here's just a couple pictures of some issues. So this initial one here is an air embolus. We can see that picture of the air that had gotten into the line. And then over to the right, we see a central line infection. And you can see the crusting, the redness around the site. It looks swollen. And then it's kind of hard to tell, but there might be some exudate there as well. So going back to, being able to prevent these complications, so we want to make sure we don't overinflate the balloon. We want to monitor those waveforms continuously and then maintain that continuous flush system as well. Another risk of having a PA catheter, and this is usually during insertion or removal, is because as your heart is an electrical conduction system. So as that's being threaded into the heart, if it hits that heart wall, it can send the patient into a dysrhythmia and kind of throw off, the heart's rhythm as it's being inserted or removal. So, something to monitor for as it's being inserted and removed. Okay, so moving on to circulatory assist devices. So these decrease cardiac work and improve organ perfusion when drug therapy fails, or they're used in conjunction with drug therapy. So this can be recovery from an acute injury, such as an MI, stabilizing before surgical repair, or for somebody that's awaiting a cardiac transplant. So going back to our patient, so aggressive medical care is heart failure does not respond to medical treatment. So we're going to go ahead and insert an IABP, an intra-aortic balloon pump. So you remember this from your word matching activity. So this provides temporary assistance by reducing afterload of the heart. So not only does it reduce afterload, but it kind of keeps that blood to perfuse the heart. You see this a lot with patients that are waiting to go to the cath lab or for a cabbage, something along those lines, where the heart has an issue where it's not getting blood from some type of stenosis or clot. So benefits, so decreased ventricular workload, increases myocardial perfusion, augments circulation, but it is, however, for temporary use only. So it consists of a sausage-shaped balloon. I've got a good picture of it to show you. The nice thing about this is it's hooked up to a machine, a large machine that is kind of doing all the work for it. It's monitoring it. It's got all of the fail-safe features and alarms. And it's a pump that inflates and deflates the balloon along with your systolic and diastolic pressure. So here's the machine. Okay, so with this, balloon is inserted into the femoral artery and placed in the thoracic aorta. That is then moved towards the heart and placed in the descending thoracic aorta just below the left subclavian arteries and above the renal arteries. And then the placement is confirmed with an X-ray before the machine is turned on to begin. So during systole, our balloon, we can look at picture A here. During systole, so when the heart is pumping towards the body, the balloon is deflated, which facilitates that blood to go into the periphery to perfuse everything. So in early diastole, when the heart is relaxing, we can look at that in picture B. The balloon starts to inflate a little bit. You can see it's starting to push a little bit of blood back to the heart, kind of shunts it back. And then in C, in late diastole, the balloon is totally inflated. So this increases coronary perfusion pressure, with the end result being increased coronary perfusion and cerebral blood flow. Typically, the assist ratio is 1-to-1. However, if the patient is starting to be weaned off of it, they might turn it to a 1-to-2 timing. So you can kind of guess just with the nature of this equipment and where it's inserted. There can be some vascular injuries if a plaque is dislodged, potential for aortic dissection, compromised distal circulation because it is at that end diastole. It is keeping that blood back into the heart. Thrombus and embolus formation are common as well. Which can add to the risk of circulatory compromise. The action of the IABP can also destroy platelets, ending in thrombocytopenia. I mentioned ischemia to periphery, kidneys, bowel, and then of course infection, especially because this is inserted through the femoral artery, which that area is dark, can breed bacteria as well. So we want to make sure that we keep that site clean and monitor for local and systemic signs of infection. So problems with the machine itself. So there could be improper timing of balloon inflation. There could be balloon leak, or a malfunction of balloon or console. The nice thing is that any type of malfunction that the machine might have will trigger those fail-safe alarms and automatically shuts down the unit. So let's talk a little bit about, what interventions we're going to do to, prevent complications from IABP. So your patient, again, kind of going back to how it is for temporary use, your patient has to be relatively immobile. So they're going to be limited to a side lying or supine position with the head of the bed elevated less than 45 degrees. That lower extremity has to remain straight at all times. That lower extremity that we're on the affected side cannot be bent at all. So when we turn this patient, we're going to be log rolling them. And as I mentioned before, we're going to wean them from the IABP by gradually reducing the assist ratio. Okay, so moving on to our ventricular assist devices. So this can provide short or long-term support for the failing heart. Inserted into path of flowing blood to augment or replace action of the ventricle, and they could be internal or external. So again, when we look at these, this was also on your word matching activity. So we can see our external one, patient is fully mobile, and they have the LVAD connected to the heart. So indications, so failure to wean from bypass, failure after MI, or this could be a bridge while awaiting transplant. End stage heart failure, maybe an indication for a ventricular assist device. Similar problems and similar care as a patient with IABP, frequent assessments and observe for complications. So goal for this patient, recovery through ventricular improvement, heart transplantation if they're using this in the interim. If there is no available treatment, then patients may choose to terminate the device.